Just to start, as you all may know, laser technology is one of the most important technological innovations that have been introduced in endourology in the past 3 decades, particularly in endoscopic stone treatment. Many cutting-edge novelties have been modifying our clinical practice in lithotripsy. As you all may know, Omnium Jack laser is the gold standard, or has been considered as the gold standard for lithotripsy over the past 30 years, thanks to its efficacy and safety profile. Nonetheless, all the lasers that have been launched recently for lithotripsy, such as the thulium fiber laser and the latest pulsed thulium jack laser, all of them to be used in this meeting, has emerged as a strong competitors to Omnium Jack. But we have to take in mind which is the ideal laser. And this question, though simple, is quite difficult to answer. For sure, but we can agree is that the ideal laser should be effective, safe, capable for multitasking. For example, and here in our group, we will have to launch a laser able to enucleate and coagulate, and to generate fan dust on lithotripsy scenarios. Cost-effective, fast, ergonomic, and noiseless. The question arises as to whether we have a single laser machine that includes all these features. The answer, as we have said before, is not easy, and that is why we are all here to put some light on the scene. Since receiving European CE mark approval in 2020, thulium fiber laser has emerged as a strong competitor to Omnium Jack, particularly because of its promising results in vitro performance. Studies have shown that TFL offers a finer dusting, it is a reduced retropulsion, and faster stone ablation when compared to Omnium Jack. So in light of this, we designed a prospective study that was conducted in our urology department between June 2022 and June 2023. In this study that enrolled 75 patients, we used SuperPulsed thulium fiber laser, SOLTIVE, for lithotripsy in retrograde intrarenal surgery for previously untreated kidney stones. The aim of the study was to evaluate efficacy, safety, and clinical outcomes in laser lithotripsy in our cohort of patients. So we use a reusable fiber active endoscope and fiber lasers from 150 and 200 microns laser fibers. Before performing laser lithotripsy, we selected short pulse mode and used secure laser settings widely accepted within the endourological community during the whole procedure. All treatments were done with a range of pulse energy, with a range of energy between 0.2 to 0.6 joules and frequency between 50 and 180 Hz. So all patients underwent preoperatively a non-contrast CT scan to achieve stone volume and stone density. The stone volume was calculated using the formula of an ellipsoid, that is 4/3 per P radius, length, width, and depth, and the stone density was measured in Hounsfield units. Data collected during the surgery include total operative time, and that is important for us, acknowledging that in a lithotripsy procedure, as we have seen this morning, for example, procedure encompasses for both lasting time and non-lasting time. For example, basketing or dissection in new ducting scenarios. So laser on time, that is the total time the laser is activated, and total energy, that is the total energy delivered by the laser machine. All these figures can be obtained directly from the laser machine. Sorry. This way, we manage to assess for each lithotripsy efficacy that we have defined as the clearance of a stone volume per unit of total operative time, that is cubic millimeter per minute of surgery, ablation speed, that is the stone volume ablated per unit of lasting time, energy consumption, that is the energy needed to ablate 1 cubic millimeter of stone, and finally we recorded hospital stay, complications using the Clavian window system, and to determine a stone-free rate, all patients underwent a non-contrast CT scan 3 months after surgery, and we define a stone-free as a total absence of residual fragments or fragments less than 4 millimeters. So these are the results. A total of 75 patients with previously untreated, mostly solitary kidney stones, were included in the study with a median age of 57 years. Pre-extended, as we have said before, was not mandatory, and only 14 patients were pre-extended due to previous clinical conditions, such as urinary obstruction or infection. The stone location was variable. Most of the stones were located in favorable positions, like pelvis, upper mid-calyx, and lower calyx locations were observed in 33% of the cases. Median stone volume was 1,320 cubic millimeters, and median stone density 1,150 Hounsfield units. So the study outcomes and intraoperative complications are summarized in the present table. So median operative time was 37 minutes and laser on time 25 minutes. Efficacy, as we have described it before, as the clearance of a stone volume per unit of total operative time was 29 cubic millimeters per minute, and energy consumption 20.5 joules per cubic millimeter. And the ablation speed was 1.1 cubic millimeter per second. So we found a tendency when compared the results with the previous experience we have with Olmium Jack laser in a decrease in the use of baskets due to a better dosing performance that was previously known for in vitro studies. Intraoperative complications were minimal and not related with the laser use. Postoperative stent was used in 31% of the cases. When analyzing perioperative outcomes and stone-free rate, we obtained a median hospital stay of 21 hours, and complications analyzed using the Clavien-Dindo classification were low, with no complications reported in 85% of the cases. The complications reported were only grade 1 and 2, observed in 11 patients, mainly bothersome symptoms related with the stent, and 3 cases of urinary tract infection. Stone-free rate we could achieve was 90.5%. So just to conclude is that our initial experience with this laser, with TFL SOLTIVE, suggests that it is a safe and effective modality for lithotripsy during retrograde intrarenal surgery, particularly for moderate volume and density stones. Further trials are warranted to compare this laser with Olmium Jack in large and more diverse populations. And we are facing, as Oriol has said, a new era with promising advancement in lithotripsy technology, and that obliges us to do the use of a standardized terminology in order to communicate results, to pave the way for more robust research within the next future. Thank you, and hope you have a nice course.